Good afternoon, everyone. Ken Murphy from GP Connections, and welcome to today's webinar. We've got Jo O'Sullivan talking about hand therapy, who's going to give us an update on some of the common hand conditions that are treated in hand therapy. Just a reminder to everyone that on the bottom left-hand screen there's a chat supervised item that you can click in there and ask questions as we're going, and I'm sure Jo will be able to help you out with any of the answers. I'll hand it over to Jo. Thank you very much. Thank you.
All right. Does that sound better now? Hopefully. So today I just have a variety of things that I wanted to cover. The next technical thing is the next slide. There we go. So just an idea of what I wanted to go through today is what hand therapy actually is, some of the common things that we get referrals from you, and then some of the other things that we treat, and some more of the interesting cases. So you're probably aware common injuries referred to hand therapy. We see a lot of burns and lacerations, a lot of wound management and scar management, fractures, lots of ligament injuries from sport, heaps of nail bed injuries from work, a lot of overuse and repetitive strain kind of injuries, tendon injuries, and then we see the more chronic things like arthritis. So when we have a patient, we generally do the wound management, edema and scar management. There's been a big push lately for pain management, and a lot of the ideas are going more centrally in terms of how we manage people's pain. We want to protect the repaired structures, get more movement, more strength, focus on their independence, and definitely look a lot at the return to work process or return to hobbies and sport. One of the things we've had some troubles with lately is people's expectations in terms of paying. So if someone has private health cover, they need to have occupational therapy in their private health cover to be able to claim. All of the therapists that work here are occupational therapists. Hand therapists can be OTs or physios, but in Queensland it tends to be they're mostly occupational therapists, and not all health funds will give money back for that, so patients can check before they come. And then if they get, depending on the type of splint, if they have a custom-made splint, it can usually be claimed under orthotics. And some health funds like Medibank Private will let them claim any splint, but there will be a cost. And the general cost for most sort of forearm-based splits would be somewhere around the $70 mark. And then the biggest splits be a little bit more than that. If they're a work cover patient, they will be fully covered as long as the claim is accepted. Sometimes if they're a contract worker or something like that, the claim may not be accepted, and then we do send the bill to the patient. So if they do have an overuse injury, it's good for them to go through the process of getting the claim accepted first so that they don't end up out of pocket. Similarly, CTP patients can be fully compensated, but we need to get pre-approval from the insurance company. So before they come, if they can find out the contact details, we can request everything, and then they won't be out of pocket. And the final group is the enhanced primary care, which is the 5 sessions through Medicare. They must pay at the time of the consult, and that's $65 for the consult. And then if they go down to Medicare, they'll get $52 approximately back from that, which means they will be out of pocket, and Medicare does not cover any splints. So usually if they have in their head about $70 for the cost of the splint, and they may be able to claim that if they've got private health cover through their orthotics, otherwise it's an out-of-pocket expense, just so that you can let your patients know. So some of the common simple injuries we see, mallet fingers are actually one of the hardest injuries to treat because every 1 mil of scar tissue between the tendon or between the fragment and the bone is a loss of 10 degrees extension motion. So if it's a large fragment, they can have surgery, but with the small avulsion fragment or just a tendon rupture, they do need to be managed quickly. And we apply a thermoplastic splint to hyperextend the DIP joint, and they're not allowed to take that off. It has to be worn 24 hours a day. If it's a tendon injury, it's worn for 9 weeks, and if it's a bony avulsion, then we can start to wean it at 6 weeks. So that would be the kind of thing we would make. So functionally, they can do a lot with the splint on. And if they do need to take it off, if it gets wet, they have to keep their finger hyperextended with their other hand or resting on the table. They cannot, during that 6 to 9 week period, ever have a time when their finger's unsupported. And we make that very clear to them, because if they take it off to have a shower and their finger's unsupported for part of a second, then their 6 or 9 weeks have to start again. And after that period, up till the 12-week mark, we do get them to keep wearing the splint at night and for risky activities. So generally speaking, we see those people in the initial appointment and then a week later to check, and then at the 6 or 9 week mark, and then depending if they need after that. The other common injury that we see, especially with ball sports, is a volar plate injury, and that again can be a tendon only, or it can be an avulsion fracture, and it's managed non-operatively if the avulsion fracture is less than 30% of the joint and the joint is stable. And there's another one where getting to see them early makes a big difference, because that ligament sort of acts as an accordion. So if it gets scarred up, they lose their ability to bend, because it becomes like a blocker to the joint flexing, but they also lose their ability to straighten, because folds of the ligament can stick together, so they end up with a really stiff joint. So generally speaking, we put them in a splint, and the splint holds the joint around about 20 to 30 degrees of flexion, and from day one they start bending in the splint. And similarly, we usually have to see them a week later, because their swelling starts to go down and the splint starts to get loose. And all of the splinting material has 100% memory, so we can put it back in the water and it'll go back to its original shape and we can remold it. So patients only have a one-off cost. And the main complication with these volar plate injuries is stiffness. And so the splint down the bottom is one of the splints we use to get extension down the track. So there's a lot more that we can do once the joint becomes stable, but the key to have the easiest path through therapy is to see them early, get them moving early in the range that's safe, and then protect the range that's not safe. Along the same lines, another common one is ulnar collateral ligament injury of the thumb. And if testing it shows that it's very lax, we're keen for the doctors to do an X-ray just to check that the little fragment hasn't slipped out over the muscle, so that it's a stenosis lesion and it can't heal. A lot of people naturally have a lot of suppleness, and so we just compare it to the other side. And if it's a partial rupture, we treat it with splinting, and if it's a complete rupture, we like the doctors to surgically repair it. So with all the splints, we try and only immobilise the joints that need to be still, so that the person can still function as much as possible. So the splints is on for 6 weeks. If they move their thumb in pure flexion extension, then they can start exercising early, but they can't use their hand functionally for about 6 weeks without the splint on. But these do stay sore for a very long time, so they may well be using the splint past the 12-week mark for work, especially these guys with the heavy lifting jobs. And with surgery, similar time frame, splint is 6 weeks full time, and they take the splint off to do a bit of exercise, and then part-time splinting for the second 6 weeks. Carpal tunnel isn't as urgent in terms of referral, and we have 2 options. We can give them a thermoplastic splint or a soft splint, and the idea is to hold their wrist in neutral. So if it's a mild to moderate case, then the splint can have a benefit, and we would trial it for 3 weeks. And if after 3 weeks of using the splint at night, and potentially for aggravating activities in the day, if after that time there's no improvement, then we don't feel that conservative management is going to do the trick, and they'll need further medical intervention. If it does help, one of the key things to make a permanent change is activity modification, and so we go through a lot with that. If they're work cover, we really encourage a work site assessment and to modify the environment so that their wrist is held in a better position, and then they can use symptomatic relief for whichever things help in terms of their pain. We do lots of stretching, and once everything settles down, then we can look at strengthening. We do often, if things seem to not be going the right way, refer them on also to the physio to just have a look at their neck and make sure that it's not coming from more proximally. 2 things we commonly see is the intersection syndrome and de Quervain's. So similar in terms of overuse of your thumb and wrist, but the intersection syndrome is where EPL crosses over the extensor muscle bellies as opposed to de Quervain's. And we will often splint these people if they wear the splint when they're working. It's a good way to modify their behaviour, and the things that they can't do with the splint on are things we need to look at, because they're often the things that do stir up their symptoms. So the thermoplastic splint is essential if it's the intersection syndrome. A lot of new mothers get de Quervain's, and for them we use more the top splint, the thumber form, just because it's softer for the baby and a little bit more functional, but it does give them some freedom to move. So people have a choice. They can use the splint, but potentially they will need to use the splint up to 8 weeks. The other option is to talk to their GP about a cortisone injection and whether that would be beneficial, and then that reduces the amount of time they need to be in the splint. And that's just for them to discuss with you. We'll fit in with whichever approach you think is best. And during the time that they're resting in the splint, we again look at activity modification and the work site assessment. And once things have settled down, then we start looking at the strengthening side of things so that it doesn't return. And I just put the base of thumb arthritis in because it is so common, and a lot of research has been done lately. There's a therapist in America and one in Scandinavia, and they've come together to make a splint called a push brace, which is the picture down the bottom. So we used to always use the big splint at the top, which does settle their symptoms, and there is research to support using that at night, that if you use the splint at night and do femur strengthening in the day, you can control the symptoms. But the push brace down the bottom has been extremely popular, and even some of the hand therapists are wearing it because it gives really good support just to the CMC joint, pushes the joint back into the correct alignment, so that there's less pain, but it gives total freedom in terms of function. Again, the femur strengthening is essential, and things like joint protection techniques, getting people not to do the strong gripping or be in sustained postures, and when they're doing the femur strengthening, we make sure that their thumb's in the correct position and not going into that Z deformity. So there's some of the things we can offer the base of thumb arthritis. I'm not sure if you've seen the Noy Group publications. The Noy Group are based in Adelaide, I think, and David Butler and Lorna Mosley do a lot of presentations, and they've done a lot of research on managing pain, and their book is excellent in terms of, I often lend it to patients to read, people who've got chronic pain conditions, and they look a lot at managing the pain from a psychological point of view and give you good resources for that, and we often also refer people to psychology. But they also offer treatment strategies like the mirror box therapy, where your injured hand goes inside a box and your uninjured hand is outside the box with a mirror on it so that you can watch the reflection. So especially people with amputations who get the phantom pain, you get them to watch the reflection and get their good hand to be massaged, touched, scratched, whatever, or moving. And if they watch and focus on the reflection for long enough, it triggers in their brain that it's actually their injured hand that's getting massaged or moving or whatever, and it actually helps to block the pain, because they say that the homunculus in the brain actually changes in response to, say, an amputation, and by looking at the reflection and making the hand look normal again, you can reduce that smudging in the homunculus. So we use that to get pain people to get started without us having to actually touch them. And the other thing we use is graded imagery, where you can actually get an app for it, and people just have to look at a hand or a foot, we use hands, and say whether it's a left hand or a right hand, and that uses the premotor cortex. So for some people with bad CRPS, that can be enough to actually stimulate their pain, but then we can grade the process from no touching to stimulating the brain, and no touching, and then on to actually doing therapy. So they have a lot of really good resources, and they've got a website where you can get them all from. If we look at some of the splints that we make, these are splints for fractures, which I'm sure you've seen. The splint at the bottom in the centre is a new one that we've just got on board. It's by DJO Global, and it's a material, all of the splints we put in hot water and melt them, and they melt at 50 degrees. So we can heat them, mould them, let them set, and then if they're not right, put them back in the water, heat and mould. The new type of splint is one that is put in a dry oven, and the benefit of it is people can swim, shower, they can go into the beach with it on. It has some strings on the side with a twist that tightens it up. So you can, as long as the fracture's stable enough, you can loosen it a bit and let the water flush through if they've been to the beach and got sand in it, and then tighten it back up again. Or you can loosen off and spray a hairdryer down to dry it off. So for a lot of people that would be very attractive. It is still removable, so I guess you have to, if someone's not trustworthy, then they should be in a plaster. But that may be a good option for the future. So the top splint we would use for Bennett's fracture or for a scaphoid fracture. The second splint for wrist fractures. The last splint on the top we would use for metacarpal fractures with the finger buddies. That's what the white tape is to the next finger along. And the bottom left is the foot drop splint, and we use those only for bed rest. So if people need a splint for weight bearing, our thermoplastic isn't strong enough, but to support in bed post-surgery, we have the option of using the foot drop splint. And just an example of a distal radius fracture, we're moving more towards surgery with internal fixation. The disadvantage of internal fixation is that people get really stiff, so they need to have fairly aggressive therapy, and it needs to start early. But one example of someone who had this done was a 47-year-old cleaner who fractured her right distal radius when she tripped on a chair at work, and she had the TriMed fixation, and therapy was commenced a week later. So I hope that comes out clear, but it was a significant fracture, and that was the TriMed fixation post-fracture. This was done in Brisbane. So there's a lot of metalwork in there, but the benefit is, at 6 weeks, this is her range of motion, and if you compare that to someone who's been in a cast for 6 weeks, she's so far ahead of the people who are immobilised, and she's relatively pain-free. So at 10 weeks she was back at work as a cleaner. She had no pain, almost full range of motion, and her strength was functional. She was avoiding heavy lifting because she was told to, just until that 12-week mark. So it makes a big difference if you can get people early and they've got really stable fixation. The people who don't have a good outcome, these are some of the splints that we use to increase the range of motion. So we get to make lots of fun things here. The splint on the left is called a Colello splint, and whenever we put force on a joint, we have to put it in the correct line of pull, which means they have to wear that cage around their arm. And you can use that for supination or pronation. And these splints will be worn up to 6 hours a day, 6 hours in every 24-hour period. But they'll start with, say, 3 lots of 15 minutes and just see how much time they need. And when we say 6 hours, that can be lots of 15 minutes, lots of half an hour. It doesn't have to be one full chunk of time. But the splint on the right, they may actually get to the point where they just sleep in it, so they get their 6 hours and don't have to worry in the day. So that splint is to increase their wrist extension. So generally speaking, we wouldn't start these splints before the 6-week mark, and then we would only start when the doctors are happy that it's stable enough for us to do that. And these are some of the splints for tendon repairs. So with tendon repairs, the splint has to be worn for 6 weeks full time. The top splint is a flexor tendon repair splint, and it doesn't matter which part of the flexor tendon is damaged, the splint needs to keep all of the fingers in that protected position. The one underneath that is for an FPL repair, and we are relying on the patient because if they could still use their hand functionally with those 2 splints, but they're not allowed to even pick up a piece of paper with their fingers. They can use it in the top splint. They can use their thumb against the side of the splint, and that's it, because the tendon repair isn't strong enough for any function for the first 6 weeks. The splint in the middle at the top is for an EPL repair, and that splint does the job of the EPL. So if the movement is blocked, they only bend a certain way to get the tendon gliding, and then the rubber band there does the job of the tendon so that they can't snap it. In terms of EDC finger extensors, the splint on the far right is the one we like to use now. It's called a Merit splint. And it's better than the old designer splint used to have because it just allows people more function, and so people are more compliant with wearing it. And it uses a system where the fingers either side help to protect the repaired tendon. And then the last picture down the bottom is a biceps repair. So they can be managed in just a sling or in a splint. And with all of those splints there, we do start exercising from day 1. So the doctors in Brisbane are extremely anxious that we see people within 24 hours of surgery. But as long as we start before day 5, because once the scar tissue starts to form, it doesn't just stick the 2 ends of the tendon together, it actually sticks everything to the surrounding tissue, and then there's more resistance and therefore more chance of rupturing the tendon. So the splints must be worn 24 hours a day for 6 weeks. They can't be taken off for showers. And then from 6 to 12 weeks, they still have to wear the splint for at-risk activities. In the research, the key point of time where people snap their tendons is in the first week post-repair, at the 6-week mark when they take their splint off, and then in about 10 weeks when the body stops producing as much scar tissue and starts remodelling, and there's a slight dip in the strength. So at that 6-week mark, I've had someone snap their tendon hitting a mozzie that landed on their face and putting their wrist. It was a flexor tendon repair, and they put their wrists and fingers into extension and just slapped their cheek to hit the mozzie, and that was enough to snap the tendon. Then I've had another person who was getting out of a chair quickly to answer the phone and put their hand down in that wrist back position and also snapped a tendon. So they need to be very cautious. Then we start strengthening at 8 weeks, and that's usually the earliest time that people would be allowed to drive following a tendon injury. However, if they have an automatic car and a spinner knob, then they can be allowed to drive one-handed so that they can get around to get to work. And then at 12 weeks, that's when we lift their precautions. So in terms of return to work, if they can work one-handed, then they can go back to work up until that 6-week mark, but it's really, if they need to be at full tilt, then it won't be until 12 weeks that they can use their hands functionally. These are some of the contraptions that we make for increasing range of motion for fingers and arms. So if people have stiffness in the joint, we aim again for the 6 hours of wear. So this top splint is to increase finger flexion on one finger. The one underneath that is all fingers and their thumb. So you can see that if people are having to wear this even 3 lots of half hour in the day plus do their exercises, their rehab takes up a lot of time. Once people are a bit more advanced, they can reduce to a smaller splint, but the smaller the splint, the more pressure is pushed on their back of their fingers and on their fingernails. So in terms of compliance, the splint has to be as comfortable as possible. So even though they look big and bulky, often the bigger the splint, the more comfortable it is. And then the splint on the far right is to increase elbow extension. So the splint on the left, the patient can adjust at home by just pulling the rubber band down further. The splint on the right, we generally remould once a week to increase the stretch. It's the same concept as braces on their teeth. It's that slow, constant stretch. A really sharp stretch for a short period of time is like a rubber band. They'll stretch it out and potentially cause tears in the tissue, which will cause more scar tissue. So it's better to have a long stretch, and the tissue will actually grow over time. They will need to build up gradually, and the splints do need to be adjusted weekly. And our goal is to get 10 degrees of improvement in the stiff joint each week. And the fibres of scar tissue are replaced every 6 weeks. So there's 6-week cycles. So splints to increase range of motion may be required for up to 4 months, but we generally go until they're 100% or until they plateau. If someone has had an injury and it's been a long period of time, an X-ray is beneficial because it may be that if their finger's stiff for a long time, they actually have degenerative changes, and that may affect our ability to use those kinds of splints. The other big area that we do is splinting for function. So musicians are very common people who get overuse type injuries. So the first picture is someone who plays the flute and who is having lots of problems with her thumb. So we don't want her to rely on the splint forever, but we don't want her to lose all of the fine motor control and not be able to participate. She's in a school band, so we want her to be able to do all of that. So we have a period of using a splint that's gradually weaned, and while the splint is on, we're resting, and then once we start weaning the splints, we need to look at strengthening. And in between thing that we've started to use lately is kinesio tape, which is a stretchy dynamic tape as opposed to fixed rigid sports tape. And the stretchy tape allows the movement, that just gives a tiny bit of support, so that's a good in-between phase. The second picture is actually a leather wrist cuff. So leather is really good for farmers, and they can make any of the styles of splint in leather. And the girl that makes it for us actually reinforces the leather with a high temperature thermoplastic, so it's stronger than our usual thermoplastic. And the leather splints are expensive. I think a wrist one is in the vicinity of $400, but they last a long time. They're like shoes, they wear in, so people find them comfortable. So the farmers who've got wrist arthritis, who don't want to have their wrists fused and have to continue heavy work, then that kind of leather splint is really attractive. And they use those as needed for function. The thumbiform is the next one along, and people use that for arthritis, for de Quervain's, and it's a good functional splint because it allows a lot of your hands to move. The picture down the bottom on the left is one of the splints that we use for rheumatoid arthritis people. It blocks the PIP joint from dropping into a swan neck position. So people with that type of arthritis will need to wear that splint for ever, or for a very long period of time. So they want something that doesn't really stand out. You can also get that designer's splint that looks like a silver ring. So for people who have arthritis who are going to need them long term, sometimes we just make it look like jewellery, but it does that job of stopping the PIP joint from hyperextending. Next picture is, we did make lots of splints for sports people. This is a cyclist who had a wrist injury and needed to get back to racing. So the splint provides support, but still allows her to be able to grip the brakes and be in control of the bike. And the last picture is hard to see, but it's another one of the newest splints that we've got. It's for a TFC ligament injury of the wrist, of the ulnar side of the wrist. And it's very small, but it just supports your wrist joint and protects that ligament, so that this was a musician who had injured her wrist but really wanted to get back to a professional musician and needed to get back to work, and with that splint she was able to still play. And this late since put out a CD. This next area, managing tone, I am definitely not an expert at, but we're getting more and more of these as people with high tone are going down the path of Botox. So currently, people have their Botox injection, and then we do a series of casting, which is the first picture, to gradually stretch everything out. Then once we've done a series of casting, we've got the best position we can, they go into a maintenance splint, which is the picture beside that. And that will be something they need to wear long term. And if people don't have function, then we can leave it there, but people are just happy with the aesthetics of having their hand look more normal. But if they do have function, the picture on the bottom left is a Lycra glove splint. So that costs about $800, but it actually has boning or the pull of the material to help support muscles. So if once they have the Botox, their flexors are looser and we can start working on their extensors, they would wear a glove like that, and we would start therapy to increase the strength of the extensors. So by the time the Botox is worn off, the extensors can override the flexors a bit more, and they can start that normalisation of movement. And it's obviously good to do that earlier on, but the people, we've seen quite a few people who are like 10, 15 years down the track, who've gone down the path of Botox. So this is a new area for us, but we're happy to help out in that area if needed. And the last picture on the bottom is the kind of splint we most often use for people with high tone in their elbow. We find that if they have the Botox and we put the plaster cast on, the cast is so heavy that it does actually help to stretch out the elbow, but if they do need something else to start to straighten the elbow with, we use a beanbag or a foam splint so that it doesn't cause any problems with their skin, but it just helps keep their elbow out straight. The other new thing that's come out is the Sabo, and we've had quite a few requests for this. You have to actually go away and be trained to fit this, and for the patient it costs about $4,000. So there's a limited number of patients that this would be useful for, but it's the way, it seems to be the way of the future, where Osmetic company has people who are trained in it. So they run workshops when they have enough people who are interested, where to date they've been in Brisbane. The patient goes down and gets an assessment, and then they fit the kit. Once that is on, the idea is that they do hours and hours of exercise every day, like 5 hours of exercise every day, and it's very boring, very repetitious. It's picking up a ball, putting it in the box, picking up a ball, putting it in the box, or picking up a cone and putting it down. about 1,000 hours of practice, and that helps to regain some normal patterns of movement. And when I was younger, the focus was definitely on making it very good, pure patterns of movement, whereas with this on, it's just getting it done. So it doesn't matter how funny it looks, they just have to keep doing it, doing it, doing it. And you can look that up on the internet, and on their site they've got videos showing people before they used it and then after a few sessions and how much more function they've got. But there's no guarantees, and it's a huge investment, and it has to have someone who's qualified, and the only person at the moment that I'm aware of is Swiss Osmetic, and it's based in Sydney. So if there was a group of people, they would come up and have a look. But just to know that it's out there. The picture on the right is a similar idea, but it is for people who don't have the elbow control. The one on the left is for people who can make about half of this and have about 20 degrees of active wrist movement, then they can use that one. And then if they don't have control of their elbow, they need the Savo Reach, which is a little bit more complicated again. So moving away from tone, the other major area that we spend a lot of time doing is wound care. So the first area is split skin graft. So generally speaking, we make a splint to immobilise once people have the graft, and that will be on for 4 to 7 days. And then we do the pressure garments. So that's a second skin garment that's custom made. We use the massage and Care or silicone. There's a few different brands of silicone, and the silicone softens and flattens the scar. So if people are worried about the aesthetics, it's good to get the silicone on early. If they're prone to keloid scarring, it's good to get it on early. And the reason this fellow can't straighten his elbow, the picture down the bottom, is because of his scar. So he went on to have surgery, and then we did all of the therapy afterwards. But there's the aesthetic side of things, but there's also function. If the scar's tight, especially in the hand, it can severely impact on the functional use of the hand. So similar to other therapy, we immobilise at wound management, the scar, massage and desensitisation, silicone compression exercises and strengthening. These are some of the local flaps that we've looked after. So the one down the bottom didn't go so well, but generally speaking, we need to immobilise them to give them a chance for the graft to take, and then we can start remodelling them and getting people to functionally use their hands. With fingertips, there's a lot of desensitisation and fine motor control that they need to do. So the local flaps are becoming more and more common. We used to see a lot of cross-finger flaps where the skin's taken from the dorsum of the adjacent finger to cover the loss of the tissue on the volar surface. The advantage is the results that you can see on the right is very good, and they don't lose their finger. The disadvantage is their fingers have to be kept still for that period of time that they're connected together, and it scares the patient to see it like that. It makes a scar on the dorsum of their finger, which they often aren't happy with, and their fingers can get stiff because of the immobilisation. So, but it is something that we treat. And then we do the bigger cases. This is a 3-muscle flap. So that's the picture when it was first done. So the second picture is him in a splint and with just very light dressing. Third picture is him in his pressure garment, and then the last picture of what it looked like at the end of the day. This fellow's arm was caught in a bobcat accident. The bobcat rolled on his arm. And at the end of the day, he got pretty much full function back. You can see his elbow's not totally straight, and he lost some muscle bulk in his forearm, so his strength wasn't 100%. But he went back to work. He didn't go back to work near bobcats again because it was a bit traumatic. But he went back to work full time, and it was a very successful outcome from something that started off looking fairly horrific. And then the most complex things that we see are replants. And this is a farm worker. We see a lot of horrific farm accidents. He was only 38 years old. He'd already had a heart attack. And he was working with a circular saw on a farm and cut off his hand. And he just had a small tissue bridge on the ulnar side left. So he cut every nerve, artery and tendon. He cut through the bones of his carpus and lost bones there. But he had 9 hours of surgery. They had to end up having mid-carpal fusion, taking out his trachleitrum, and then there was a plate put in there which was removed later down the track. His tendons were repaired, except for his little finger FDP and his APL, and the nerves and some veins were repaired. And at 6 weeks, this was hit the functional use of his hand. So this is after his splint came off. And you can see, especially the picture in the middle, he didn't have, the nerves hadn't returned down to the intrinsics of his hand, so he had an ape hand with the loss of intrinsics and loss of vena muscles. But his long tendons were working. He was extremely motivated, and he kept working on light duties on the farm pretty much as soon as his wounds were healed. They gave him light duties and he went to work there. This is another one of the bigger cases that we had. This was a young fellow who was a fitter from Brisbane, and steel fell off a crane and crushed his thumb, and they had a go at replanting it, but unfortunately it failed. So a week later the thumb was removed, and once everything settled, they looked at a toe to thumb transfer. So we were involved initially in the wound management and splinting. Once the thumb was removed, we did all of the scar management and kept function in his stump. And then he went on to have surgery. So they don't take the big toe as much anymore. They take the second toe because aesthetically it looks better. They walk better. They attach the little toe on, but if you see from the x-ray, it has an extra joint, so they have to put a K-wire across that. So that's what he looked like after the surgery as it was still healing. And then this is his function at 4 weeks. So his thumb will never have flexion at the tip, it will be fused, but it's more as a pole or something for your fingers to oppose against. And you can reach across to his ring finger, so he has some opposition. So considering having no thumb or having this, it's much more functional to have this. It's a lot of surgery to go through, and you're probably looking at 6 months rehab, so you have to choose the right patients, and we were lucky enough to have patients who were very motivated. And they have to be very careful. They can't drink a lot of alcohol, they can't smoke at all because it can damage the blood vessels, they can't have caffeine, chocolate. There's a lot of limitations. And to date I haven't had a transplant of the hand, but they're often presented at the conferences we go to. So hand function is a complex integration of motor, sensory and cognitive functions, and effective rehabilitation requires a coordinated and timely treatment. And that's the sloth that I met in South America named Buttercup. So I just put the last slide just where we are and our contact details, but happy to take any questions.
No, looks like you have covered all of the concerns and questions for everyone, Joe. Once again, very much appreciated, and we will sign off and let everyone get back to their busy days. And once again, thanks very much, Joe. Very much appreciated.
Thank you.